What's going on, guys? How you
Here
guys
we
doing?
grow again. Hi everyone. Oh, that was at the same. We talked at the same time.
We
That's
did. It's kind of weird.
that's it's kind of annoying. Sorry about that, guys. But welcome back to getting that medical degree.
Today
What's
we'll be
today's
talking
topic?
about Parkinson's and everything you
Ooh,
know for the Naplex about it.
all right.
Let's get into it. Do want to start off saying that this is kind of a sneaky chapter because you don't think Parkinson's is that important for the Naplex, but on my two Naplexes, I've had Parkinson's about 8 questions total between the two tests. So that and Alzheimer's, they like some reason they like these chapters. I have no idea why. So yeah, something you guys should probably know. Anyways, the major symptoms for Parkinson's include TRAP. That's the easy way to remember it. So tremors, rigidity, akinesia, and postural instability. I just like to picture like an old man with a cane, walking and shaking while he's trying to walk down the hall. I don't know. That is how I picture it, and that's kind of how I remember the symptoms. Probably not the best way to do it, but it's pretty visual and you can see it in your head. Guy hunched over, walking, just shaking really bad, walking towards a pharmacy. Yeah, that's how I picture it, and that's how I kind of remember the symptoms. I like trying to turn everything into like any disease state that has symptoms. I try to like picture it in my head and actually like draw pictures in my notes about it and be like, hey, this is what this looks like, and that's kind of how I remember the symptoms. So I guess for every disease state. Next up is AIMS. That's kind of the scale they use to measure how bad someone's Parkinson's is. AIMS is abnormal involuntary movement scale. Imagine that. Um, it measures involuntary movements, so it's kind of it just shows you how bad their Parkinson's is progressing. I don't really know the numbers on the scale because this is for pharmacy, not MD or PA school. So yeah, I just need to know like, hey, this is what this is. So if they have Parkinson's disease and they have depression, we talked about depression in another video. You basically
Yeah.
use the first line options: SSRI, SNRI, nortriptyline, or desipramine. You're probably seeing use an SSRI or SNRI. Nothing really special here. Now, next up, you have psychosis. Now, psychosis is where it does get a little different. Psychosis, quetiapine or Seroquel is the preferred agent, but can cause some metabolic complications. That basically means weight gain. When you ever see that, usually means weight gain or weight loss, but in this case, it's weight gain because Q is kind of a fat letter, so it's weight gain. That's the main drug you'll want to use for this because quetiapine causes weight gain, but doesn't cause like shaking issues. And so if someone has Parkinson's disease, you want to avoid any medication that can cause like shaking issues, which a lot of like the antipsychotics can actually cause shaking issues. So Seroquel is preferred. You can use clozapine, but it is a REMS drug, which means there's a lot of steps that have to be involved for it to be prescribed. Then the pharmacy has to be signed up in the REMS program, and it's just a big mess. Plus, there's a lot of monitoring with it, so the ANC, which is the absolute intrathecal count, needs to be greater than 1,500 to even use it, and you want to stop if it goes below like 1,000. It has a high risk of like seizures and agranulocytosis. So basically, don't use clozapine unless like it's a last line option. Just use Seroquel and keep the patient safe. Now we got that out of the way. How do you really treat this? So you're basically replacing dopamine because this is like a dopamine deficient disease. It's kind of how this happens. So basically, you use carbidopa, levodopa, which you probably heard of before. It's the brand name Cinemet. Levodopa is the precursor of dopamine, and the carbidopa is used to inhibit the dopamine decarbolase enzyme, basically the enzyme that kind of destroys dopamine, or levodopa in this case. Carbidopa kind of inhibits that, so lets the levodopa do its work. The CR version of it can be cut in half, and the IR, which is an immediate release, starts at 25/100. You do need 70 to 100 milligrams of carbidopa to inhibit the enzyme, which is pretty important to know because they do ask that in the test because that's kind of like a kind of thing you pick up in the pharmacy. Like, hey, this dose is actually less than 70 to 100. This is useless. Why are we giving this to the patient? So that's like prompts you to call the doctor and figure out what's going on. But long-term use of this can lead to fluctuations in the use. So, like, if you use it for a very long time, it might just stop working for the patient or it might not work as well. And you can also use like a COMT inhibitor, which increases the duration of levodopa. And it has to be like, it's only used with levodopa doses of 200. Well, 200 milligrams by mouth with each dose of levodopa. So, next up is your dopamine agonists. These are, again, similar to dopamine. Side effects involve like sudden daytime sleepiness, orthostasis, hallucinations, fun stuff. Again, no brand names, so these are pretty important to know. Pramipexole is Mirapex. You can see that both words have pex in it, so it's pretty easy to remember those. Roperidol is Requip. Tigotine is Nupro. Important to know about Nupro is it is a once daily patch. Apply at the same time every day. And do not use the same site within 14 days, so yeah, the patient's going to be moving that patch all around their body. And also remove the patch before MRI. Apomorphine's the injection, remember that. The dose is written in mLs, not mgs. Again, remember that. And then the test dose, so you first use it in the medical office. Again, that's important too. So all three of those things right there are test questions that I've been asked before on either practice questions or on my actual exam. Use for rescue movements for an off episode. And you don't want to use it with the 5-HT3 antagonist due to severe hypertension. And yeah, that's it for that. Next up, you have some other medications. So you have amantadine, which blocks dopamine reuptake. Can cause dizziness, sleepiness, levodio reticularis, and psychosis. You also have selective MAOB, which blocks the breakdown of dopamine. It can cause serotonin syndrome, which you want to avoid with other medications, such as like serotonin medications, such as your SSRI and SNRIs. Also avoid like linezolid as well. Segolene is Zelpar. It's Activane, so don't take it at bedtime. And that's really about it on these ones. Not too much to know, except make sure don't take it at bedtime. So next up, you have central acting anticholinergic. So benzoprine, cogentin, know that. Side effects: it's an anticholinergic, so it's going to dry you out. So constipation, dry mouth, urinary retention, blurred vision. I'm going fast because these are things that you should know when I say anticholinergic. Just think of drying out, and these are all the symptoms that should come to your mind. Adenosine antagonist is used to reduce like the off episodes. This is istradifilin. And alpha and beta agonists you can use for neurogenic orthostatic hypotension. That's droxidopa. Again, going with the other medications, you have amantadine. I already talked about these guys, but yeah, I'm just showing you those ones again. That's it, guys.
All
So
right.
really just know the main drugs, know the drug names, drug side effects, and really anything weird, like knowing if it's like an injection, it's an mLs, or if it's a patch. Just really know those inside and out, and you should be good. That's it for this video, guys. Like, comment, subscribe, and we'll see you
All
in the
right.
next one.
Give it a thumbs up, everybody. And bye.
Bye.